So hello everyone, my name is Martin Reck. I'm a pulmonologist and I'm working in Grosshansdorf, which is in the north of Germany. And I had the pleasure and the privilege to attend the European Lung Cancer Conference this year in Paris. And I also had the privilege and pleasure to present an update on the KEYNOTE-799 trial. Well, the KEYNOTE-799 trial has been a phase 2 trial exploring concurrent immunotherapy pembrolizumab with simultaneous chemoradiotherapy and consolidation with pembrolizumab. And what we presented in Paris was a long-term follow-up. So now we really have the 5-year follow-up data for this new concept. And the idea is really to move the immunotherapy from the consolidation part to the active chemoradiation part in order to enhance the immunogenic reaction of our treatment. Well, in the KEYNOTE-799 trial, we enrolled 216 patients with a stage 3 unresectable non-small cell lung cancer. We had 2 cohorts of patients, one cohort A with the histology of squamous and non-squamous non-small cell lung cancer, and one cohort B with the histology of cisplatin and pemetrexed. All patients received 1 cycle of chemoimmunotherapy, and then they had the simultaneous chemoimmunoradiotherapy followed by the maintenance with pembrolizumab. In cohort A, we had a backbone chemotherapy, which was a combination of carboplatin and paclitaxel. And in cohort B, we had the backbone chemotherapy of cisplatin and pemetrexed. Well, we had 2 primary endpoints. Number 1 was the toxicity, in particular, the pulmonary toxicity greater than CTC grade 3. And there we had a boundary below 10%, and we observed somewhat grade 3 pulmonary toxicities in the range between 6.9 and 8%. So this was feasible with an adequate selection of patients. The secondary endpoint, or the second co-primary endpoint, was the response rate, and we observed a response rate of more than 70% in both of the cohorts that we investigated in the KEYNOTE-799. Now, with a longer follow-up, we do have mature data on progression-free survival, and I have to look on my score sheet. So we had a median progression-free survival, which was between 29 and 45 months. And I think more importantly, when we look on the landmark analysis, the 4-year progression-free survival rates, we are in the range between 39% and 42%. We also do have overall survival data. So the median overall survival was between 35.6 and 56.7 months, with a 4-year overall survival rate of 40 to 75%. Overall, these are very encouraging and robust data showing a sustainable efficacy for this quite intensive concept of simultaneous chemoimmunoradiotherapy in patients with locally advanced non-resectable non-small cell lung cancer. And this is clearly a concept which should be evaluated in a phase 3 trial. This is now being done. We have the KEYLYNK-12 trial, which has completed its recruitment, and we are waiting for the final readout of this trial. Well, in the same session, we also talked about management of stage 3 non-small cell lung cancer in patients with oncogenic-driven non-small cell lung cancer, in patients with EGF receptor mutations. And there we do have the LAURA trial exploring a consolidation treatment after chemoradiotherapy with the EGF receptor TKA of osimertinib. Well, we have seen last year that this consolidation treatment with osimertinib did lead to an improvement of response, did lead to a significant prolongation of progression-free survival, together with an overall acceptable tolerability. Now here at ELCC, we had the first glimpse on the overall survival data. We had a new data cut which was presented, including also some additional results on overall survival. And now we indeed do see a trend in improvement in overall survival following the treatment with osimertinib after chemoradiotherapy in this group of patients with EGF receptor mutated stage 3 non-small cell lung cancer. So this is clearly a very active and as well tolerable new treatment opportunity that we do have for these patients. number one is what is really happening in the field of stage 3 non-small cell lung cancer. And there we have to wait for the results of the prospective trials. We also had some, let's say, negative readouts coming from phase 3 trials. So we really have to see how this will work out. Perhaps we also have to look on an intensification of the consolidation treatment. This is something which is going on. But overall, we do have now in our hand that we have the opportunity to offer more and more patients, even in stage 3 non-small cell lung cancer, a very effective treatment opportunity and a very attractive perspective to prolong their survival, or at least to have a very solid prolongation of their stabilization of their disease. We have heard a lot about stage 3 non-small cell lung cancer. We are working now also in the field of, let's say, optimizing the individual treatment in this group of patients. And this is a lot about determining something that we call the minimal residual disease. There we are talking about liquid biopsies. What is the signal of liquid biopsies following chemoradiotherapy, following immunotherapy? Can we really schedule our treatment individualized to the single patients, and what is going to happen in the future? So we have a lot of considerations, trials, they're ongoing. We will present some upcoming data from the perioperative setting at the next ASCO meeting in Chicago. And overall, what we are learning is that the treatment in stage 3 non-small cell lung cancer is moving into a very personalized field of therapy. And this is also something which we already have learned in stage 4 non-small cell lung cancer. So we are getting away from the very rigid schedule of therapy, the rigid schedule, just chemoradiotherapy, to a more individualized approach where we are utilizing different treatment opportunities that we have developed for our patients with advanced non-small cell lung cancer, depending on the molecular profile, depending on the tumor size, but also depending on the comorbidities and the performance status of the individual patient.